welcome to ComplyPlus Presents. I'm joined today by Dr Richard Dune. How have things gone for you this week, Richard?
Been interesting.
Yep.
There's always something, I think, in health and social care in general now, there's always something interesting going on because obviously every week there's something that the government is doing
Yes.
to change things that you didn't expect at all. But anyway, look, that's a story for another day, I guess.
Yep, that's the roller coaster that
We
is
could almost do a podcast every week about what has the government done this week.
in that specific department, let alone
Exactly.
all the others. Yeah. Well, you
Yeah.
are seeing a lot more political podcasts now, and
Yeah.
there's a lot of content. But
Yeah.
without further ado, we are going to discuss what I hope to most of you listeners is quite interesting, to others maybe not so, but we're going to dive into something that causes a lot of confusion in the sector, and that is CSTF statutory and mandatory training. So, as a kick-off, starting with the basics for some of you that may be new to the sector, some of you that may know what CSTF is but are not quite sure, what exactly is the CSTF?
So we're talking about a framework that was developed by Skills for Health in 2013. If you go back to that time, it was a very difficult time for the NHS. But then when you think about it, sort of think almost every period is a difficult time for the NHS.
Yeah.
But just to give context, we had coalition government, the Conservatives and the Liberal Democrats were the first coalition government in a very long time. So David Cameron as Prime Minister, Nick Clegg as Deputy Prime Minister, George Osborne, Jeremy Hunt, those people were in government. And Mid Staffordshire, NHS Foundation Trust scandal, it just blown out. Everyone was shaken, actually. It was really almost like a classic example of how not to run a healthcare organization. And part of the problem was that the lack of training or standardization of training, where if you have a lot of agency workers, for example, like in this case, Mid Staffordshire, we're using a lot of agency nurses and doctors. The training that they've done, whatever they've done the training, does it match the standards that are expected? And if you move from one NHS trust to another NHS trust, are you doing similar training? The learning outcomes, are they the same? And are you following the guidelines, the legislation? So the whole idea was to sort that out, to standardize training, and to also avoid unnecessary duplication. Because as you can imagine, if I'm working here in the Midlands, I move from Coventry to Birmingham or Leicester, I'm still in the same region, and my training is up to date. Then I get there, I'm asked to do all the training all over again. So looking at about 15, 16, 18 subjects just to do them all over again. So that was the idea, to say, look, we need to standardize training so that the quality is the same everywhere you go. And there's unnecessary duplication, unnecessary costs as well. But obviously, it started in the NHS. And even within the NHS, it took a while to understand what it was. Many NHS trusts did not want to do it. I know that for a fact because I know people that were in learning and development, people that are doing resuscitation training. Well, we follow the Resuscitation Council guidelines anyway. And we work with the Resuscitation Council. Why do we need this additional layer of governance? And, people it took a while because it wasn't compulsory, but it took a while for NHS trusts to be convinced. But obviously, if you're running a recruitment agency or a private healthcare organization, it became the standard that you follow. And it also now went beyond NHS staff because most of the private healthcare companies, their staff are coming from different places. Then they also think, hang on, if we can use this as the gold standard, and people like gold standards in healthcare.
Yeah, it's a buzzword, isn't it?
Yeah, exactly. Something that I can follow. That's a benchmark that I can use. So gradually, it became accepted. And for some frameworks, actually, if you want to bid for work, if you don't have training that is aligned to CSCF, you know for a fact because you had to fill in all the forms with our trainers.
Yes.
And get the sign-off from Skills for
Declaration
Health.
of alignment.
Declaration of alignment and things like that. So we want to break down some of these myths that are still around because people still get confused. Even care homes are saying, we want CSTF aligned. And you think, okay, yes, we can adapt it, but it was not meant for adult social care. It was meant for healthcare. Even the language, even the focus is focused on
The
healthcare
examples.
organizations. Yeah.
So ultimately, we're helping avoid duplication, particularly obviously when there's movement of staff between different services.
Exactly, which is quite common. Moving the staff. It's that's become the standard because there's a shortage of staff. You're going to use locum staff, agency staff, even agencies like NHS Professional, which is like the NHS agency in a way. They have to follow similar practices because they are supplying staff to different NHS trusts as well.
Yeah.
Yeah.
So even though it originated in the NHS, it is now being widely used across various other services.
Yes, because it's a core skills training framework for healthcare.
Yeah.
Essentially, that's what it is.
Yeah.
And we have worked with private healthcare organizations, for example, like some of
Yes.
the medium to large private healthcare companies, independent companies. They have to follow the same because it standardizes training, and also even the way they are inspected by the Care Quality Commission. There's an expectation that they are adopting most of the things that are being done in NHS trusts because you're providing a healthcare service, you're running a hospital. No matter how small it is, you still need to have that governance framework. And if there's a national set of national learning outcomes that are there, a set of delivery standards, refresher expectations for key subjects, then it's an expectation that it's going to be standardized across the board, whether you're NHS or not. So yes, it's now widely adopted across the sector, even primary care, GP practices, dental practices, because there was, to be fair, actually, although there was criticism, and there's still criticism, and even I could spend a whole day just picking holes in the whole framework, but it helped actually to bring some standards in an environment where there were far too many people delivering training that had no basis at all in legislation.
And there was no standard. Yeah.
Exactly. So it was needed. Things are never perfect, but I think it actually helped to standardize, and I think it's still got a long way to improve. Like the latest version that is there, it was last done in June 2021. We were still dealing with the COVID-19 pandemic.
Yeah, 4 years old.
And now we're in 2025. If I was to use that, or if our trainers were to use that as a guide, it's outdated in many ways. There's so many things that have superseded what's in that framework. And you sort of think, so do we float? I don't want to go into a political conversation or even as to whether these organizations are fit for purpose, but actually they are so outdated. If we used it, actually, everyone would fail their inspections. Patients would suffer.
Yeah.
Yeah.
Couldn't agree more with that. So we've talked about what it is. Now let's look at who it's for, who it's aimed at. So who, in your mind, is the CSTF aimed at?
So we said healthcare providers, right?
Yeah.
So the NHS to start with. And now we also have the agencies, the recruitment agencies. We have agencies that are also providing CQC regulated services. So they are registered with CQC, but also running agencies. I did mention primary care services and care homes and domiciliary care companies. Skills for Care have since brought their own framework.
Yeah, and that's more appropriate.
Even we had to, when there was nothing in place for care homes, we had to adapt the CSTF for adult social care, domiciliary care companies and care homes because there was nothing in place. But now the Skills for Care have done a lot of work, actually. I think in many ways they've probably done much better than we expected. And there's a better framework now for adult social care. But otherwise, NHS trusts, private clinics, people that are providing healthcare services, because even the language that is used, they talk about patients. So if you call your client group patients, then it applies to you. But if they're a resident, then that's a care home, residential home, or supported living services. Yeah.
Yeah. So the important distinction is that CSTF is role-based, not necessarily job title-based.
Exactly, because even within the NHS, it's at different levels. So a lot of the subjects are at level 1 awareness. So it means that all the members of staff have to do them. Then, if I give resuscitation as an example, you find that in most places, level 2 suffices. if you're in the community, for example, basic life support level 2. So it covers level 1 learning outcomes and level 2 learning outcomes. You can do CPR, you can use the AED safely, and you know how to call for help, you know how to do chest compressions, you can help somebody who's choking, you can deal with an incident of anaphylaxis. But obviously, if you are now working in a clinical environment where you're giving medicines, where people are higher risk, you probably need now immediate life support, which a lot of nurses have to do if they're working in A&E or in ambulance services. They might even need to do advanced life support as well if they have responsibilities to run resuscitation teams. So although it's just one subject, it's delivered at so many different levels depending on the role that the people are doing and what their responsibilities are, as well as the needs and level of risk in the environments that they're working.
Okay,
Yeah.
excellent. So we know what it is, we know who it's for, we've clarified some of the misconceptions there. So what does the framework actually cover? We know that there's 11 subjects. So Richard, if you talk us through those 11 subjects and give us a brief overview on all of them, just so that the audience has got a bit of an understanding on what it's going to cover.
Yeah. So the main framework itself is 11 subjects. So these are subjects that, at the very minimum, you have to do.
Yeah.
So regardless of what service you're providing, for example, conflict resolution.
Yeah.
We know that violence and aggression against healthcare professionals is increasing. You know, people that are working in ambulance services, in A&E, even general wards, violence is increasing. So how do we reduce that? But also, how do we communicate with service users, for example, their loved ones? Because if people are in pain, they want something, and sometimes actually we can't. Like, for example, if you go into A&E, you're going to wait a few hours, and people get frustrated. But we have to prioritize who we treat first. So it's important. The Health and Safety at Work Act is clear about protecting people within the workplace. There are several other relevant regulations relating to violence and aggression. Blended learning, some subjects can be done online, the theory side, like communication skills. But obviously, if people are working in mental health settings or any where they may need to people are violent. Actually, the risk of violence is higher.
Physical restraint.
Yeah, physical restraint. Although we avoid restraint as much as possible, but people have to be trained in breakaway techniques and where needed, maybe restrain as well. Then there's equality and diversity and human rights. So we talk about EDI, and it's beyond just race, because people think it's just about race. No, it's men and women or not or other. Right? You're talking about religion or lack of, things that people value. If somebody is pregnant in the workplace, what happens? So the Equality Act and the 9 protected characteristics come into play there. And on the CQC side, that can also be the area where we show how caring our organization is, because it's about delivering person-centered care. And generally, it can be done online, now mostly done online, and it's refreshed every 3 years. Then we've got subjects like health and safety at work and fire safety. So fire safety, you've got the regulatory reform, fire safety order from 2005, where we need to do our risk assessments, and we put preventive measures in place where people need to be trained to use fire extinguishers. Then they are trained to do so. They need to know evacuation techniques. So refreshed, in most organizations, they do an annual refresher when they do the fire safety risk assessment. Then they do a refresher. But otherwise, every 2 to 3 years, health and safety is the same as well, promoting proactive site-specific risk management, because quite a lot of companies do it online because it looks so simple, health and safety. But actually, that's where a lot of organizations fail to meet the commissioner requirements and the regulatory requirements, because they're just doing generic courses. They're not doing course assessments within their own organization. So control of substances, hazardous to health, REDO reporting, accident reporting, incident reporting, near misses. Infection prevention and control is another big one. It has to be role specific as well. All members of staff have to do it, but people do it at different levels. If you're a nurse who's going to be doing dressings, giving medicines and all that, there are a lot more high risk procedures that you're dealing with. So you can spread infection. So you need, or actually pick up an infection yourself. So we need to know about the pathogens, the chain of infection, and how to break that chain. Waste management, laundry management, things like that, hand hygiene, most importantly, as well.
Yes.
Then you have subjects like information governance and data security awareness. Other people may refer it as data protection training or cardiac training, depending on the setting that they're working. But generally, all staff have to do it, but it's also role specific. Imagine somebody at reception. How much information are they handling when they're on the phone? How much information? It's not just digital information. I think there's a misconception that when we talk about data security, we're talking about online, say, security for data, but actually even physical notes. Even when I'm talking on the phone, even who I give information to verbally, if they don't need to know, then I shouldn't give them that information.
Yes.
So there are very strict rules around, from the Data Protection Act as well as GDPR, UK GDPR. And we need to be aware of data breaches as well and what to do when there's a data breach. And the role of the Information Commissioner's Office, making sure that we have people that are responsible for protecting data in the organization. You have moving and handling and manual handling. So manual handling of objects for people that may be porters, security, people that don't have direct clinical roles. They still do a lot of manual handling, even admin staff. But also people who are delivering services, care services, nurses, doctors, care workers, they all need to do manual handling as well. There are specific regulations like manual handling operations regulations, lifting operations regulations as well. We have the safeguarding suite where we have some things like the prevent radicalization. So most of the staff have to do the basic prevent awareness. So those are safeguarding duties because in healthcare, we see a lot of people at their most vulnerable. Yeah. And people that are vulnerable are also at risk of being radicalized, taken advantage of. So it's our duty under the prevent strategy, and we need to know how to escalate issues, how to raise concerns, and follow the organizational requirements. Safeguarding adults in general is about keeping people safe from harm and abuse. It's one of the biggest failure areas actually when it comes to CQC inspections. People not picking up safeguarding issues, people not reporting them, people not escalating them, people not following their policies or not even having meaningful policies as far as safeguarding is concerned. And even if you don't work with children, you need to do at least up to level 2 safeguarding children if you're a nurse, you're a doctor, because you're dealing with patients that also have children, that will have access to children. And if they are a risk to children, that needs to be raised as a concern. Multi-agency working as well. You work with the local authorities, social services, police. So it's really important because we keep having all these safeguarding failings. Every now and again, a child dies or older people are abused in care settings, in healthcare settings. We don't seem to be learning and we don't seem to be strengthening our systems.
No.
And the last one is resuscitation. I did talk about it earlier. So yeah, it's really important that it's covered properly, and also we know our risk and the patients that we're supporting as well, what risks they carry.
Excellent. So that's a really helpful overview. Hopefully all of you have found that very useful.
We probably need to do a separate session.
Yes, I think
just covering the individual subjects.
I think the team have got us planned for an 11 episode marathon to go through each of them, because obviously some of those areas we've discussed there, you could deep dive, and as Richard rightly said, we can do an episode on each of them quite easily. So some of the topics overall are quite practical, hands-on based. Others are more policy based and a bit more theoretical. So yeah, I don't know if you want to add anything to that, Richard, before we look at delivery methods.
Yes, every subject is a theory element.
Yeah.
And even with resuscitation, I remember when I used to work in the NHS, I would do advanced life support. So when we did it first time, they send you a big booklet that you have to read.
Yeah.
And so you have to know about the emergency medicines, the crash trolley, where you keep all your emergency equipment. We had the defibrillators. It was manual ones back then. Then we went to the automated ones. Then you do your reading for nearly a month. and then you go in and write an assessment. Then you spend a whole day doing practicals. So you're doing clinical skills stations, and either you pass or you fail. And then you then come and do your refreshers. So the theory can be done online nowadays. Or people still get booklets, that's okay. But the practical elements like moving and handling, resuscitation, you have to do hands-on practical assessments and demonstrations, role playing, right, to assess people's skills and their ability to be able to go and do what they're supposed to do in the workplace. Fire extinguishers, for example, if you're not trained to use a fire extinguisher, I always say to people, don't try to learn how to use it on the day, right? People need to be trained. If there's a high risk, then they need to be trained to use the equipment that is within the workplace. Medicines management, although it's not in the CSTF, interestingly, it's one of those very high risk environments. When you look at Regulation 12, safe care and treatment, it's one of the biggest failure areas for any organization, whether it's healthcare, adult social care. Most of them that fail are failing Regulation 12, and then obviously good governance as well, failing to protect people. So medicines management, people need to be trained theory-wise, but also face-to-face, even how to break medicines, which sort of medicines you can break, and how do you break them. What about using pumps? And giving IV fluids, IV medications. How do you mix them? What needs to, a lot of these things actually, when you think about it, you think for nurses, for example, they spend 3 years at university, then they go to placements. Then when they finish, they still need to be supervised and signed off. So it's not enough to just do online. Practical subjects need to have practical assessments, and then people getting signed off that they're competent now to go and work independently. Yeah.
Excellent. So let's have a look at delivery methods and refresher intervals, because this is always a big area. How often do we have to redo this training? We know it's not the most popular thing among staff to have to do, but it is important, and compliance is king in this area. So let's talk about how the training should be delivered, and can providers just do it all online?
You have to have your own training policy as an organization.
Yeah.
So when you do your policy for whether learning and development or training, you cover induction training, right? So what are people going to do when they get a job? They need to know about the organization in general. So in NHS, they call it, I think it's a corporate induction. Then when you've done that, so you're learning about the culture. The CEO would probably come and say a few words and wave. They talk about health and safety. They talk about car parks and things like that. Then you then go to your specific area that you're working. Then you're now doing induction and onboarding to your role, right? So the policy should set the induction training that is required and onboarding. Then it should also have a needs analysis section where we've assessed our needs, and this is what doctors need to do. This is what nurses have to do. What level of training do they need to do it? Is it done online? Is it face-to-face? Is it blended? How are people assessed and certified? And how often do they have to do the training? So the CSTF does have some guidance on every subject.
Yes.
For example, resuscitation, moving and handling, fire safety, infection prevention and control, information governance, they're done annually. Then the rest are done every 3 years. But there's a caveat to that. If there's an incident in the organization, then you need to review everything. You may need to retrain people straight away.
Yes.
If the legislation or regulations change significantly, then you may need to stop and think, hang on, how does it affect, what is the level of risk?
Service,
and how do we mitigate that risk? Do we need to retrain people? You may not need to retrain everyone. It may be just a matter of giving people information, right, in staff meetings or through the internet to say, look, things have changed. This is how we're now doing things. But you have to be confident. Healthcare, there's so many risks, and some risks are higher than others. The reason why you need to do refresher more often in the practical subjects is because in some areas, I've seen nurses and doctors that have gone 25, 30 years without resuscitating anyone at all.
Yeah.
So imagine if they don't do regular refreshers.
Yeah, that's that one time.
Yes, that one time that they're needed. Then they can't do what they're expected to do. So again, I've learned quite a lot, because when you work clinically and they're dealing with very poorly patients. Like I worked mostly in cardiology, coronary care, and emergency departments across the Midlands, working in resuscitation units. So you see people that at any time can deteriorate and die. So you have to monitor them very closely. So you're very risk aware. Then you go and work in environments where people are so relaxed because they don't see it every day. And then something happens there. In most cases, actually, the outcomes are not very good because people are not exposed. And sometimes people don't take the refresher training seriously because it doesn't happen here. We don't get patients like that, So it's really important that the culture also around risk awareness and risk mitigation, with a positive culture towards that, because I think there's a tendency to say, well, it doesn't happen to us, it doesn't happen here, it's never happened here. Or just a few people in the organization taking it more seriously than others. I've seen that as well, where one person is not on shift, everything changes.
Yeah. Standards drop, mindset drops. Yeah. We've seen all the stories in the news, haven't we? So yeah, we know it does happen. So yeah, I think that's a really interesting point. So if we look at now how these frameworks align to legislation, but more importantly, the CQC regulation side, which is why a lot of this training is being done. How does the CSTF help with the regulatory compliance?
It's a guidance document. It's not compulsory for you to follow it. But if you use it as a starting point, like I said, it's quite out of date right now as we speak.
Yes, ironically, yeah.
And I don't know whether they know that it's out of date.
Or if there's plans to update it.
I'm sure they do, right? But, it's a guidance document, and the guidance document, you should treat it as such. It's a guide to get started.
Yeah.
Then you customize it to your organization,
to your business. Yeah.
You should always look at your local needs. So you do a needs analysis of your organization. You do a training needs analysis, different staff groups. You could have nurses working in different departments. Like I said earlier, if a nurse is working in a respiratory unit or in a coronary care unit, it's very different to a nurse who's working in a rehab unit where people are just waiting to go home, right? The risks are different. That one is acutely unwell. The other side, actually, you have people that are medically fit, just waiting to go home, maybe just doing the last bit of rehab, right? So it's important that we use our professional judgment, and we also, sometimes you might even need legal guidance, right, to apply things properly. And we've worked with organizations to do the needs analysis. Then when it comes to the Care Quality Commission, how does it help? Any training that you do is usually done to mitigate certain risks, to meet certain legislation or regulations. Because when you think about it, what is statutory training? It's the training that the law says you should do.
Yes.
What is mandatory training? It's the training that you as an organization, on top of what the law says you should do, you do your own risk assessment. So each of the CQC regulation, whether you're looking at Regulation 12, Safe Care and Treatment, you're looking at Regulation 17, Good Governance, Regulation 18, Staffing and Competencies, each of the training that you're doing is done to meet one regulation or other, right? And it's up to you as an organization to say, look, how are we cross-matching these things to make sure that actually each of the regulations is covered. Our training actually is fit for purpose, right? Then when you think about it as well, to say, look, what are the CQC key questions, the 5 key questions?
Yes.
We need to be safe as an organization, so staff are trained to protect people.
Yeah.
Right. Safeguarding, health and safety, infection prevention and control, all that comes there. Safeguarding is quite crucial, right? And then when you look at effectiveness, it's training evidence-based, actually. Are we up to date, right? That's what organizations need to do, to scrutinize, to make sure that they're up to date. Then caring, we did talk about person-centered care. We talked about equality and diversity and inclusion. All that is important for people to understand, treating people with dignity and respect, right? That shows how caring you are as an organization. And even when you do the evidence for the I statements, for the we statements, that's where the survey questions are coming from, right? Then when you look at responsiveness, people's needs change regularly. Again, depending on the nature of service that you're providing, but people come in with all sorts of needs, and some of them are uncommon, So we need to be always prepared for uncommon needs, which we don't deal with as regularly.
Yeah.
I've known times where a whole unit is shut down because we're thinking one of the patients has TB, tuberculosis.
Yeah.
So even the staff now, this is way before COVID, we were doing that, where we think that actually there's a communicable disease that can spread across the whole hospital. We lock down that ward and change everything. Everybody goes into that mode where they shut everything down. They wear PPE, they restrict movement, and even staff members that have been exposed there can't go anywhere else, right?
Yeah.
That's responsiveness, right? But actually, if it's not emphasized in the training, how do the people know? Quite often, training is done out there. We've talked about leadership now. So say, look, when you think about the wider governance framework, training is a tick box. That's what I've realized over the years. Even the
Becoming
organizations that are asking for the best quality training, you give them a report, you do a needs analysis, they want to do the cheapest form of training.
Bare minimum.
The bare minimum. We load people in a room where we talk to them all day or talk at them all day. We give them a certificate and they're done for the year.
Yeah.
We're still seeing that up to now. We've fortunately stopped that because when we started out, we used to just take any job, thinking that we could change the world. But then you realize actually
it was also because we were confident in what we did as well.
We were, right? Because what we did was, even when we took the jobs and did them, we said to them, look, you've done this. This is only scratching the surface. What you really need to do now is this.
X, Y, and Z.
But then they think, they want to take more money from us.
Everyone thinks
and,
it's
and then in the end, what we realized was we are flogging a dead horse.
Yes.
We need to change our model. And thankfully we did. Because yes, as a private company, you need to make money, you need to be profitable. But there are just some forms of training that they're not going to work. And we don't want to be associated with them.
And they're not going to, like you say, build a sustainable and thriving business.
Exactly.
They're going to tick a box every year, and that is it. So, look, we know that these training records do become a key part of the evidence trail. We know that these certificates are what auditors, inspectors are looking for. But like I say, I think, especially when we go on to our next point, there's a lot more to it than just shining certificates at inspectors.
Inspectors are very smart people.
Yeah.
Commissioners as well, local authorities or NHS commissioners, they know all the little tricks that some providers are trying to pull. And sometimes also ignorance where people don't realize that what they're doing is putting their business at risk.
Yes, I think there is a lot of ignorance as well.
Exactly.
In defense to some providers.
Exactly. So it's about understanding, learning also about the regulatory framework. What are the expectations if you're a registered manager, you have the nominated individual, and also doing your due diligence. That phrase is used in corporate settings, but when it comes to some of the smaller providers, particularly that don't have company lawyers or they don't have a legal team or clinical governance teams. I've seen even large organizations that have no clinical governance teams. And you think, how are you functioning when you are providing services to tens of thousands of people annually and you don't have a governance team, clinical governance team? They have a good corporate governance team, but they don't have a clinical governance side of things. So it's important really that training is consistent, it's fit for purpose, it's evidence-based, and it's mapped to our organization. Just having a certificate does not mean that you are compliant.
Yeah.
In many organizations, that's where they're getting it wrong. We send people to do their training, or we ask a trainer to come in, we sit them in a room, get them to watch some videos, get them to answer some questions. We do another day, and we tick everything off. We're fine. We're done for another year or two. Many organizations, that's what they're focused on. Of course, it's important to have the evidence that you have done the training.
Yeah.
But actually, one of the things that good inspectors do and good assessors do is to see how well the training is being applied.
Exactly.
And I can tell from a mile, just walking into the organization, just talking to one or two people, you can tell
where they are,
the culture. And you and I have been to many organizations, where you walk out there thinking,
well, sometimes it can just be walking through the door and straight away. The gut feeling is that, what's really going on here? Yeah.
Attitude to compliance has to change. And I think that's one of the biggest problems in the sector right now, where people they use training as a tick box and they don't map it to policies. They don't map it to their governance framework. It's not even discussed in board meetings. It's quite easy to tell that organizations are just ticking boxes.
Yeah.
But some good organizations do that meticulously. We've worked with a few where everything is mapped, and where they're not clear, actually, they seek help. They get consultants to come in or experts to come in or reach out to other organizations to ask how things are being done. You don't have to spend that much money. You don't even need to be an expert yourself. You just need to find the right people to help you build a good system for governance.
Yes.
Yeah.
Excellent. So in terms of practical tips now for implementing this, what should providers do to get this right?
Okay. So we did talk earlier about doing your needs analysis. So once you have your training matrix, you make sure that it's linked to the policy, it's linked to the different teams, the multidisciplinary team. So each of them, actually, what is expected of them. Then you need good systems, training management system, learning management system, where you can track completions and expiry dates. Because obviously, if things are out of date, then you're non-compliant straight away, right? Then include training discussions in supervisions and appraisals, in team meetings, in board meetings. You need to discuss that. You need to show that actually you're thinking about training and development, and how you are going to evidence it and the evidence base behind it. Assessing completion records as well, especially in high-risk areas. And where people are doing e-learning provided by outside organizations, you need to go through that e-learning yourself as well. You may need to customize certain elements, or you may need to add certain elements once people have done the e-learning. So you need to assess your e-learning providers and make sure that they are fit for purpose, they meet your requirements. Then keep certificates and sign off for competencies up to date. Ideally, have an integrated system where you keep all these things, because sometimes actually people run around looking for the folders on the day.
Yeah.
Right. And
or between different logins and different
exactly.
software applications.
Exactly. Yeah.
So ideally, we want to get rid of this tick box mentality, isn't it?
100%.
That's one of the biggest problems, as we touched on earlier. Yeah.
So training is not about dates or even just certificates. It's about ensuring that people have been trained, their attitudes have changed, their skill base has improved, and they're confident to go and do the job
on the front
that
line,
they've been trained to do on the front line. And they know when things are going wrong. They know how to escalate. They can tell that a patient is deteriorating, and straight away they'll flick into emergency mode, get the crash trolley, call the ambulance, start compressions, give oxygen. People that are trained properly will be able to switch.
Yeah.
From a normal day to a day where everything is crashing, they should be able to adapt because they are trained to respond.
Yeah,
to emergencies like that.
Yeah. I think, like you say, the competency side is like you said, really important, and evaluating the quality of the training just by asking some of those questions there to your members of staff will go a long way. So, look, we're going to wrap the episode up now. So, overall, statutory and mandatory training isn't just red tape or another compliance headache. It is there to help.
Definitely. It's the foundation of good care. Yeah. Statutory and mandatory training gives you the foundation, because the way I look at it is you, as a patient, would you want to come and be treated by your team?
Yes, I think that's always a good way of
I know managers.
assessing things.
I know managers who don't trust their teams.
Yeah.
I know managers who come and tidy things so that they can pass the audits. And I know a manager who was doing that, and they only was off sick for nearly 2 months. They failed every single audit.
Yep.
So that shows you that sometimes we are putting sticky plasters and ticking boxes, but when push comes to shove, actually everything collapses. It's like a house of cards. Everything shuts down. So it's really important that we use, frameworks like the CSTF help us as a starting point.
Yes.
They don't give us all the
That's
answers.
all they are.
And then we customize our policies and procedures. We built our own systems so that we are confident in those systems and we can justify them. So that even if it's a commissioner you're bidding for work or a regulator asking you, you can confidently say exactly what you did and why you took certain decisions. Like for me, for example, if you were to ask me to set up training for an organization, I would start from the CSTF for a healthcare organization, but I'll heavily customize it. I'll have to look at the latest guidelines and legislation. We have a new government right now. Well, it's no longer new. They've been in power nearly for a year now, isn't it? But
Yes.
they've made so many changes. What do those changes mean for my organization? You always have to be thinking about that. When things happen, are you going to conferences? Are you going to peer groups? Do you listen to the news? Do you have alerts about CQC? Do you have alerts about Department of Health and Social Care? Do you have alerts about NHS England or whatever organization that is that you have to pay attention to, so that whatever changes are happening, you adapt? And it's the same for NHS Trust. I'm not just talking about private companies here. Sometimes these organizations, there's a sense that they are so big, right? When you think about it, if you're employing 8,000, 10,000 staff, and you've got 2,000 volunteers, even volunteers need statutory training and mandatory training. You've got apprentices, you've got people working in a lab, you've got people working at the back of the hospital somewhere that nobody has ever been to, right? Every single one of those, we need to know that they're trained properly. They can look after themselves. They don't put others at risk. And they know what to do in emergencies. They're handling data. All these things are crucial. So it's a big job. I don't envy people that are working in a lot of these huge organizations with responsibilities like this. It's a serious job, which is heavily underfunded, not taken seriously.
It's the time element as well, isn't
Yeah.
it? We had a meeting the other day, didn't we?
Yeah.
Where we were looking even in our own business about
Yeah.
time boxing and how do you make time for some of these things? Because when working in the front line, you know, you've worked in A&E and these chaotic services, the last thing you're thinking about is my training up to date, or have I read this policy recently on the changes in the, you know, in the foyer or in safeguarding or whatever. But like you say, the real world is that if you fail on these things, there's no business.
Exactly. You say that actually. I remember the last the last time I worked in a hospital unit directly was in 2017, and I was working in A&E. I just literally just made myself work in A&E. I was thinking, okay, if I
Challenge
could
yourself.
challenge myself, and it was really challenging. You know, I did long days, I did twilight shifts, I did night shifts, I did weekends. I said, look, this is a test. If I don't, after 3-4 months, then I'll just go and do research and leave this. And that's exactly what I did in the end. But I remember whenever you start a shift, the people that are responsible for training and development in A&D are literally coming and begging you to go and do the e-learning, but they know that you haven't got the time.
Yeah.
And they say that, I should say, look, I know we are very busy, but just try to find time to do this training and that training, and think I'm not even having a proper break.
Yeah.
Sometimes I forget to drink water. Sometimes I
miss lunch.
I miss lunch, or even going to the toilet, you know, because I'm so busy with these cubicles and patients in the corridor. How do you expect me to go and do an e-learning course? Who does this right now? And when I'm at home, I'm not going to log into my computer to do this because I need to rest.
You're tired, yeah.
So it's a real challenge. You know, we shouldn't underestimate this. And then I think even politically as well, politicians and leaders in the NHS, in independent organizations and primary care, they need to be honest as well, right? Yes, we have shortages of staff. Yes, we have all these other challenges. But actually, one of the biggest problems is around training and development.
Yes.
Not just statutory and mandatory training, but also all the other continuing professional development that people need to do.
Yeah.
When you get new equipment, for example, sometimes people hardly get meaningful training to use new equipment.
Then they have to use it on a patient.
But then you're supposed to be using it in practice. Is there any, any surprises as to why then a lot of incidents are linked with equipment?
Things go wrong, yeah.
People with back problems. You look at healthcare workers, more than 50% of healthcare workers have taken time off in the past few years because of a back problem or other injury. So it needs to be taken more seriously. And even the Care Quality Commission framework as well, I know they're doing a lot of work now to strengthen the inspectorate and also listen to what's happening. But it comes with the funding as well to make sure that training and development is funded properly.
Yeah.
We have experienced trainers. We give them time actually to build meaningful training programs, fund them to do it. Otherwise, they'll use the same slides every year.
Yeah.
Outdated,
And where we,
not effective. So it's a big challenge. And it's, I want to emphasize, because most of the time we're talking about smaller to medium-sized organizations, but this applies across the board. And you know that because we have worked with quite a number of organizations, and we still support a lot of organizations in this area. The frustrations are the same everywhere you go.
Yeah,
Yeah.
100%. So thank you very much for that, Richard. So, as I say, I think we've covered everything we wanted to cover today. Just as a little prompt, if people do need any support with building CSTF training or accessing CSTF training, building training matrices, looking at policy, we do have all these tools available on ComplyPlus LMS. So as always, do engage, do speak to our team, do go to the website. You'll find a lot more information on this area. We've got some really good blogs on this as well, if it's something you'd like to read over a coffee or on your commute. You've also got this episode, which will hopefully put you in the right direction as well. So, but other than that, we will be back next week, and thank you very much for listening.
Thank you for joining us today.